Hey, well, good afternoon and welcome. I am Matt Price with the Price Group. We have quite a few names trickling in. Happy to see a lot of familiar names, a few new names as well. So welcome to all. And we have the honor, the privilege to listen to Jo Middleton today speaking about Medicare. Medicare is a very niche area, something that we put a lot of time, effort, and energy to keep up with and to understand, most specifically how it pertains to your Live Well plan, your roadmap, your retirement financial plan, that is. And so we are corresponding with Jo's team, and it's not just a one lady show with Jo. She has an entire team that stands behind her, and happy to report, I think I've spoken to most all of her employees, and they all truly are a delight and very easy to work with. I was trying to think before the call. I couldn't come up with an exact number, but we've referred dozens and dozens and dozens of clients to Jo over the years, and I don't think we've gotten one bad comment back from clients. So she does a great job of at her own craft of helping us with our clients, specifically with the Medicare side. And so she's prepared a good presentation kind of on some of the where to avoid stubbing your toe. You know, we get a lot of questions when we're presenting these Live Well plans on Medicare. Think of us as more maybe as a general practitioner. So we know enough to be dangerous. We also know when to refer you out to a specialist, and Jo is the specialist that we've really enjoyed working with over the last 10 plus years. So with that, Jo, I've probably missed a few things. Feel free to fill in where I did, but take it away, and look forward to hearing the presentation.
Perfect. Thanks, Matt. I appreciate it. So I'm going to try to get this screen share done first so that way, there we go. All right. Hopefully you guys can see that. Matt, do you see that on the screen?
Yes, ma'am.
Okay. All right. So yeah, IT is not my strong point. So wanted to be sure that I get that up on the screen first. As Matt said, my name is Jo Middleton. I own an agency called Trademark Insurance Agency. We do all branches of insurance here. I really handpicked, hand trained the entire Medicare team here. I've been focusing on Medicare for the last 13 years. I've been in insurance for 20. So it was a pleasure to meet Matt and Randy Price quite a number of years ago, and we've done lots of different events together. And my team and I truly do love being a Medicare resource for the Price Group, answer all of those hard questions about Medicare. So today, what my intention is, I've done several different kinds of webinars, but we thought this might be something interesting that you might be interested in hearing a little bit about some of the changes in Medicare and some of the myths. So we had some major changes that happened in 2025 because of the Inflation Reduction Act. So I'm going to go over that today. And then I'm going to give you a little bit of a sneak peek of some of the things we might expect to see in 2026 now as a result of one big beautiful bill. So without further ado, then let's get started with, is Medicare going broke? Okay, so basically, Medicare is not immediately going broke. Projections indicate that some potential funding needs to be fixed within the next decade because we've got a declining birth rate, we've got increasing healthcare costs, and also chronic disease rates. So just to give you an idea, Medicare is actually turning 60 years old this month. So it's not quite old enough to get its own Medicare yet, but it is, Medicare is actually 60 years old this July. And as Dwight Eisenhower said, that the issues going on with Medicare are something he would call important, but not urgent. It's a bit like that balloon payment on your mortgage. You know it's out there in the distance, but it's not something you're worried about right this minute. Or to give you another analogy, it's a little bit like having a roof that leaks sometimes. Okay. Now, since Medicare is a 1 trillion cost per year, you can bet your life it will become urgent soon enough. And it's definitely going to need attention by 2036. So we literally have a decade. Medicare is a federally funded or subsidized health program. And basically, the way that Medicare works is you've got your Part A, which is funded basically from payroll deductions. And so think of it like a checking account. When you guys pay in your Medicare, FICA taxes, that goes in to fund your Social Security and your Medicare. And then we spend that money out of the trust fund when we have Part A expenses like hospital, etc. So right now, because of the shrinking worker to beneficiary ratio, that has reduced the number of payroll taxes that we're getting in. So there is a danger here that, we could be, having a little bit of a bankruptcy situation going on with our checkbook because we don't have as much money coming in as we have going out. Now, make no mistake, we've got about 200 billion in excess at the moment, but it doesn't take long for us to spend through that money. Now, Medicare Part B is actually funded by premiums. So Part B is the part of Medicare you use the most. That's the part that we pay for when we activate. And the cost of Medicare Part B is based on income. So the more money you make, the more money you get to pay. But I want you to understand that the money that you are paying for your Medicare Part premium only covers a fraction of the expenses that we use for Medicare Part B. So basically, about 70% of the money needed to fund Medicare Part B comes from the general budget. So I'm telling you guys this because I want you to understand that, as you'll see at the bottom, there's lots of discussions here about Medicare should be covering expensive weight loss scrubs, and they should be covering dental and vision and all of these things that we want Medicare to cover. But I need you to understand that, unfortunately, right now, we're having a hard enough time covering what we're already covering. If we cover more things, more money is going to have to come out of the general budget. And then secondly, you can expect that your Medicare Part B premiums will go up exponentially as well. So this is one of those things where I like to say, careful what you wish for, because all of these things that we want Medicare to do, they sound great, but usually the government often doesn't think about some of these unintended consequences. So one of the other things that's putting a strain on Medicare currently is the rising cost of prescription drugs. About 14% of Medicare spending is currently on prescription drugs. And you're probably aware, if you're involved at all in any kind of political anything, that the federal government is wanting to and has started to do negotiation on certain drugs. Pharmaceuticals are by far much more expensive here in the US than they are in other countries. That's always been a big topic of discussion. And there's going to be some other things that you'll see in the future as well that will, contribute to that. So let's go to the next slide. So the Inflation Reduction Act was passed on August the 16th in 2022. But just like any other bill that the government passes, it usually takes a few years before we really start to see some of the things that happened. So this law brought about big changes to Medicare Part D, which is what covers prescriptions, and it affects all types of Part D coverage. So on Medicare, you have two ways to get your prescription drug coverage. You either get it by buying a standalone prescription drug plan, we call those PDPs, or you get it as part of your Medicare Advantage plan that has drug benefits, and those are called MAPDs. And the changes to the drug coverage started in 2023, but it will continue all the way to 2032 with this bill. So here were the big things in the bill, and they started on January the 1st of this year. The first thing was that we talked about it for a long time, but we finally got rid of the prescription coverage gap. And we often called that the donut hole. That was a phase of coverage in the prescription drug coverage where basically all of your copays and everything flew out the window, and your cost of your prescriptions went up exponentially. So that finally went away in January of this year. We also put an annual out-of-pocket max on prescription drugs, and that max for 2025 is $2,000. And I'm going to show you a little bit more about that on another slide. The other thing that this bill introduced was a prescription payment plan option. The government calls it MP3. Because Medicare prescription payment plan, right? M and then 3 Ps. I tend to call it the drug layaway plan, and we're going to talk a little bit more about that on another slide. And then it also required prescription drug plans, the actual insurance carriers and the drug manufacturers to cover more of the cost of the drugs. So until this really happened in January, the federal government was still covering about 80% of the cost of the prescriptions. Now they're only going to be covering, since January, 20% of the cost. And so the insurance companies, for the most part, have picked up most of this. And it's caused some pretty unintended nasty consequences, which I'm going to show you as we go through this presentation. So this is how drug coverage works in 2025. We have a deductible phase. You have to pay the full cost of your drugs if it's covered under the plan's formulary until you reach the deductible if that drug applies to the deductible. And the government tells the plans how much that deductible can be. So in 2025, the maximum drug deductible is $590. Once you've met that deductible, you're in the initial coverage phase, and you're going to pay up to 25% of the cost of your drugs, usually in the form of paying a flat copay, or you might pay some co-insurance. And you're going to do that until you have spent $2,000 out of pocket. Now, when you hit that $2,000 cap, sounds like a lot of money, but trust me, I have some clients that, they could spend that just on one drug. Then they hit the catastrophic phase. And in that catastrophic phase, as long as the drug is covered on the plan's formulary, there is no cost for you for the remainder of the year on the drugs plan. So on this slide here, I want to show you why this was such a big deal. So in 2024, you can see the deductible was a little bit less. It goes up every year. In the initial coverage phase, you stayed in that phase until you had spent $5,030. Now we've lowered that down to $2,000. And then you paid 25% of the cost of all of your drugs until you've spent $8,000 out of pocket, and then you got to pay zero. So you can see there's a big difference between where we were in 2024 and where we are now in 2025. You've got a bit, a $6,000 difference between how much you are really going to pay for your drugs out of pocket. So this was a good thing. This is how the prescription payment plan works. So it's a new program, and it gives somebody on Medicare the option to pay for their prescriptions on a monthly basis rather than all at once. So the way it really works is, let's say you go to the pharmacy in January, and you go to pick up Xarelto, which is a blood thinning drug, which is quite expensive. It's over $600. So rather than that drug which would normally apply to the deductible, the pharmacist saying, well, you owe $590 and some for this drug because it's got to be paid towards your deductible. If you sign up for this prescription payment plan, you basically get to walk out of the pharmacy without paying for the drug at the time of collecting it. And what will happen instead is the insurance company that is providing you with the drug coverage will now send you a bill, and they'll take the cost of that drug, they'll break it up into however many months there are left in the year, and you pay a little bit for that drug every month. Now, that sounds like a great idea, but here's where some of the issues sometimes come into that. So let's say you've got a $600 drug and you go pick it up at the pharmacy window and you have, it's January, you're going to pay $50 a month for that one drug. But let's say you take the drug for 1 month and you have some nasty side effects, and now you're not going to take that drug again. you don't get to forego paying the other $550 for the drug, right? The drug costs $600. You still have to pay for that drug, whether you are purchasing, because you've already taken a 30-day supply home with you. The other thing that adds to this, which adds to the confusion, is once you sign up for the prescription payment plan, all of the drugs are opted in. You can't say, I want to pay for my expensive drugs on the plan, but my inexpensive drugs, I'll just, pay the pharmacy cash for that. So it's sort of a moving target. Every time you add a new drug to your portfolio, you go pick it up at the pharmacy, that bill that you're going to get from your insurance company is going to keep changing as it keeps adding up these extra drugs. So what we found, and this is what I predicted was going to happen for clients that signed up for this, whereas it can be a help if you need help paying for your prescriptions, there was a lot of confusion that comes along with it, and a lot of people just don't understand what this bill is, or how they're paying it. So good example here of a great idea. It's just been a little bit challenging in terms of the implementation. At least that's been our experience. So in order to be eligible to enroll for this plan, it's optional. You don't have to opt in. But usually it's going to be people that have drugs that are more than $600 for a single prescription that might opt in. The pharmacy will tell you, or should tell you, about the program. They'll provide you with a benefit notice, and then you can opt in or opt out of this plan at any time during the year. Now, most drugs under Medicare are covered under Medicare Part D, D as in drugs, but there are some drugs that will be covered under Medicare Part B, B as in boy. Usually these are infused drugs or injectables. And oftentimes, there's a big confusion which part is covering drugs, but this prescription payment plan only pertains to Part D drugs, not Part B. So I'll give you an example of Part B drugs. Chemotherapy, if you're having that infused, that's covered under Medicare Part B. So it's covered under your original Medicare. And the other drug that's often covered, which I see a lot with my Medicare clients, is bone density injections like Prolia. That is normally covered under Medicare Part B as in boy, not D as in drugs. Okay. And so as I've got on here, it's your beneficiary will receive a bill from the insurance company for the cost of the drugs rather than paying the pharmacist. So that's how that plan actually works. So on this slide here, I want to tell you a little bit about what we saw as a result of the Inflation Reduction Act that happened starting in January. These are some of the things we predicted, and they've certainly come to pass. So there are a lot of people that are truly paying less for their drugs in 2025 than they did in the past. But we found we've got a lot of clients that are actually paying more for their drugs. And the difference is going to be this. If you've got really expensive drugs, some drugs can be thousands of dollars. You are going to be somebody that's going to pay less for your drugs because you've got a $2,000 cap. But a lot of drugs got shifted in the plan's formularies. Maybe the drug had been a tier 2 previously, it got moved to a tier 3. It's now subject to deductible, and it wasn't subject to deductible in the past. So usually those sort of maintenance drugs, those are the people that we saw that from 2024 to 2025, they ended up actually paying a bit more for their drugs than previously, because the drugs got put in a higher category, and they then had a higher copay. We also saw many more plans taking flat copays out of the drug benefits. So, it may have been like a $5 copay for tier 1, a $10 copay for tier 2, a $40 copay for tier 3. I can definitely tell you that I'm not sure I can think of any drug plans now that have a flat copay for tier 3 drugs. Actually, I can think of one. All of the others went to coinsurance. So again, this would be an example of where your drug might be costing you more money in 2025 because you're having to pay a percentage of the cost of the drug now, not a flat copay. The other thing that we saw that we predicted was that the premiums for the drug plans were higher in 2025. Now, what was interesting about this is when the plans filed their benefits, if you remember, 2025 was, or going into 2025 was an election year, right? Lots of things happen on an election year. And the insurance companies filed their drug plans, and several of them, or quite a number of them, were filing premiums for these standalone drug plans that were way over $100 a month. And the federal government said, wait a minute, oh my goodness, we just never anticipated that these drug plans were going to have such a big increase in premiums. And it was because the insurance companies are now paying a lot more for the drugs. So what the government did was they said, well, this is an election year, and that is not going to sit really well with our voters. So they went to the insurance companies and said, okay, here's the deal. We will provide you a subsidy for the next 3 years to help offset some of this extra cost you're going to have. But in return, you cannot increase the premium for your plan more than $35 each year. And of course, every carrier took what I call the bribe and said, okay, we'll sign on for that. So many plans did increase their premiums by $35, but that was a far cry from what they were going to increase them for. And we're going to see the same thing in 2026, 2027, because again, it was a 3-year deal that they signed up for. We saw many, many more drugs applying towards the deductible. And we also saw that many Medicare Advantage plans added drug deductibles, whereas in the past they maybe didn't. And this was, the next point is the big one. A lot of insurance companies looked at how this was going to affect profitability and their ability to offer drug plans, and basically dropped out of the market. So in 2024, we had 22 drug plans in and around the Texas area, and now we are down to 15, and I am predicting there'll be even less in 2026. So that's never a good thing when we have less choice, right? We also saw that on the Medicare Advantage plans, so those are the all-in-one plans, they, as a result of having to spend more on drug costs, they had the luxury of shifting some of that cost around. So instead of it being just about the drugs, they said, well, we're just going to, have higher co-pays to see specialists or higher co-pays for hospitalization. They were able to take that extra money that they had to spend on drugs and say, all right, well, we'll just shift it and make some changes into our other medical benefits. Of course, the standalone drug plans don't have that option. And then the other thing that we saw is that the insurance companies also said, we're going to have to make some major cuts to the extra benefits. And these are the things that make Advantage plans very popular. Dental, vision, an over-the-counter allowance to buy things like vitamins, Band-Aids, colds and flu medications. Lots of plans had these benefits, and we saw in 2025 that the dental got slashed. They're still offering it, but a lot less. The over-the-counter benefit went away, or it got slashed quite a lot. So again, these were some of the unintended consequences that I'm sure the government didn't think was going to happen, but these are some of the things that did happen as a result of having to shift the risk here for the cost of the drugs. So on this next slide, I'm going to give you a sneak peek of what's going to happen now as a result of the One Big Beautiful Bill. So we're going to keep the prescription payment plan. You won't have to re-enroll if you're already in it, but if you didn't enroll, you can choose to opt in or you can choose to opt out. The out-of-pocket max, that was $2,000 in 2025. We already know that's going up to $2,100 in 2026. The insulin cap didn't change. It's still $35 a month or 25% of the negotiated price, whichever is lower. And no deductible can apply to insulin. Adult vaccines are now going to be fully covered under Medicare Part D with no cost sharing, even out of network. So that's a good thing. For the Medicare Advantage plans, they're going to see an increase in their payments. So they're going to get between 5 and 7% increase in how much the government is paying them. So that's going to be extra funding to the insurance companies to provide benefits. But we're going to see some tighter restrictions on these extra benefits. So now the insurance companies will be limited with what they can offer as far as extra benefits, and they're going to have to show the government that these extra benefits, because they cost money, are going to be tied to a chronic condition, and that this benefit is going to be able to have a positive impact on somebody's health. So we saw a little bit of that last year. We had a particular insurance company that had, I think, don't quote me on the amount, but it was something like a $40 a month over-the-counter benefit. But they said, if you have one of these chronic conditions, and we can prove that you have one of these chronic conditions, now your over-the-counter benefit is $80 a month, right? So again, proof that, and it was things like having high blood pressure or high cholesterol, and being able to get supplements and things like that that could, impact your health. That was a way that they could, offer more benefits based on a chronic condition. So we're going to see a lot more of that in 2026. I think we're going to see a lot more of these extra benefits just totally being stripped out of plans and making these Advantage plans much more like original Medicare in terms of what they cover. We haven't seen them yet. We won't see them till October the 1st. This is just a crystal ball situation that I'm telling you right now. We're also going to see some more structure on appeals and the coordination of how appeals are processed, some patient admission safeguards in terms of when you are admitted to the hospital. So they're going to tighten up some of the rules, and we're going to see more unification with ID cards and health risk assessments and things. Again, these are things they're leveraging with the insurance companies to try to wrap their arms, the government try to wrap their arms around how are these insurance companies spending the money that we're giving them to take care of these Medicare beneficiaries. And everything has to be tied to, are we helping people get healthier versus allowing them to stay sick? So those are some of the things. Now, some of the things that you also want to be aware of is the Part D deductible is going to go up again in 2026. The government has said maximum deductible will increase to $615. That doesn't mean your plan will have a $1,615 deductible. It just means that the government has said the insurance company is allowed to raise it to as much as $615. So we'll wait and see what happens. And then again, I mentioned earlier that Part B, how much you pay is based on your income. So anything you pay above the standard premium is a surcharge. It's called IRMA. And I always like to say in Houston, IRMA's is one of my favorite Mexican restaurants, but that's got nothing to do with this. This is that surcharge on your Part B. It stands for an income-related monthly adjusted amount. And we're going to see some changes in that, which we do every year, on what those premiums will be for both Part B and Part D. So, there'll be an inflation, index increase. So it probably won't be horrendously horrible, but it will definitely go up a little bit. So these are some of the things to expect in 2026. I don't think there's anything too earth-shattering in here. But, unfortunately, the government tends to be very reactive, not proactive, in a lot of different things. And I think that, at some point, they are going to have to pay the piper on how do we continue to keep Medicare solvent for the future. Both administrations, both the Biden administration and the Trump administration promised that they would keep Medicare solvent. In Britain, we'd say they're all talk and no trousers, right? They like the sound bites, but they're very low on the details on how we're actually going to do that. So, stay tuned. We're going to have to start working on it sooner rather than later, but it's something they just keep kicking down the road. So those are some of the changes we're expecting. Those are the things that I was planning to give you information on today. This is how you can contact my team and I. If you have specific Medicare questions, of course, I'm just talking globally to you today. But Matt, I'd like to open it up if anybody's got questions, either about anything that I've shared today or just general Medicare questions.
Yeah, well, Jo, thank you so much. Super helpful and a lot of granular details there. I already have 3 questions that have come in. If anyone
Okay.
attending has a question, feel free to type it in the chat box and I'll share it with Jo. Jo, while maybe a few are still typing questions, give us a 30-second synopsis of what it looks like to engage with your firm. We refer you.
Mm-hmm. Yep.
And so they call, walk us through kind of how you hold their hand in a proverbial sense and help them select a plan.
Yeah, absolutely. So basically, it's a CMS. CMS stands for Centers for Medicare and Medicaid Services, part of the government that governs Medicare. It's a CMS rule that we as brokers are not allowed to make an outbound call or first contact with a Medicare beneficiary. So if Matt says, hey, Jo, Mr. and Mrs. Smith here need some help, here's their contact information, my team and I are not allowed to reach out to you. So that's why you'll hear Matt and his team talk about, here's their information, you need to make the first contact with us. Doesn't matter if it's an email or it's a voicemail, as long as you've made the first contact, we can reach out. We would like you to reach out to us if it's questions about turning 65 and, going on Medicare at that point. Start that process about, 3 to 6 months at least out from when you're going to turn 65. If you're coming off of an employer plan, reach out to us 60 to 90 days in advance of your retirement. Because we will walk you through the steps of how do you enroll in Medicare? How do you interface with the Social Security office in order to do that? We'll give you step-by-step directions. Then we'll ask you to fill out some information for us so we can find out a little bit about what your health, your wealth, your lifestyle, etc. is, what you like about your current coverage, what you don't like, so that we can then begin the process of learning a little bit more about you and running quotes and coming up with some solutions for you. We usually do our meetings via Teams or Zoom when we move into our new offices, which we are hoping to do within the next 3 weeks. We will be able to do in person with you if you really want to do that, but everything is electronic, all of the applications. But we actually spend about an hour to an hour and a half with each client going through everything that we have prepared, in terms of and explaining exactly how it works, what to expect, what it's going to cost. And we process the enrollment as well. And when we process that enrollment, that's when we become your agent of record. Unlike calling, 1-800 whatever you see on the TV. We're a pretty small office here. We've got a small team. So when you call in, you're going to get the same people that you're going to be talking to. We encourage our clients to call us, not the 800 number on the back of their ID card, to ask any questions. Sometimes these companies insurance companies, especially during that busy time of the year, they staff up with all kinds of people that, can only read off of a script. My team are going to give you the exact answer. We're not going to read off of scripts. And we want to be just like your relationship is with Matt. We want that relationship with you so that even though your insurance company may change over the years in terms of your insurance carrier, as brokers, we can facilitate that for you because we work with multiple insurance companies.
Good answer. Thank you. Here's our first question, and one, quite frankly, I hear a lot from clients.
Yep.
I'm about to turn 65, but still working. Do I need to apply for Medicare? That's
a great question. We hear that all of the time too. And the first answer that I tell people when they ask me that question is, that depends. There is no yes or no answer to this question, right? So it depends on several factors. So the first thing in terms of do I need to do anything depends on the size of the company that you work for. If you work for a company that is, as by Medicare standards, a small employer, that means there are 20 or fewer, or actually 19 and fewer employees, then yes, you have to enroll in Medicare A and B, because Medicare would become your primary insurance and your employer plan would be secondary. If you work for an employer with 20 or more employees, they don't have to be on your health insurance, they just have to work for the company, then you definitely don't have to do anything at all. We often recommend you, if you want to stay on your employer coverage, of course, that is, we often recommend you enroll in just Part A. But before we would definitely tell you that, we want to know a bit more about the health coverage you have. You know, do you have a high deductible health plan? Is there a health savings account involved? We'll ask you a multitude of questions, and then we'll be able to give you a specific answer of, based on your specific situation, here's what you need to do. So unfortunately, Matt, that's not a yes or a no question. It's, I need more information, and then my team and I can give you direction.
Understood. We had a kind of a very similar question come in. My employer is requiring me to move to Medicare. Most likely, if that's the case, it's because they have fewer than 19 employees.
Yeah, so technically, if there are 20 or more employees, the employer cannot require that you move to Medicare. But if it's under 20 employees, yeah, then they can require that. And really, the reason the employer is doing that is for your protection, because if you don't have Medicare first, you know, then as your primary payer, the employee are on the hook for the 80% that Medicare would have paid, right? So that's likely what's happening there. But, you know, again, anybody that has these specific questions, you can always call the office and we can dig a little bit deeper into your personal situation and, you know, give you more specific answers.
Thank you. Next question. I have access to a supplemental health plan from my employer. Can you help me compare that plan to a third-party supplemental plan? Is that a service y'all offer, Jo?
Possibly.
Okay.
I need to know a little bit more about what that is, but generally speaking, if you, you know, normally we don't charge for our services, right, Matt? So, you know, we are paid by the insurance companies when we become your agent of record. So we do a lot of work on the front end with you. And then how we normally are paid is we're paid by that insurance carrier. But if you're going to ask us to evaluate some plan that you have that obviously we have no chance of administering, usually the only person in the office that does that is me. And yeah, and I do charge a fee for that, because obviously I have to do the research on it and then be able to spend time with you, you know, kind of going through what your plan looks like. So yeah, usually if I do that, it's going to be based on a fee.
Okay, understood, and well worth its fee, I imagine. Another question that came in: how long into retirement until I can use a potentially lower income level for the premiums that Medicare charges? I think they're
Okay,
referring
yeah,
to the
yeah,
IRMA.
sure. Yeah, so basically, you don't necessarily have to wait until into retirement. So we have a chart that we can share that you know, shows the income levels, right? And so there's about 6 different income levels and then an appropriate premium with that. If you can look at that income chart and go, all right, well, now that I've retired, I have dropped an income level, you can immediately file an appeal with the government. There's a form to fill out. It's an IRMA appeal form. It's form number 44 on the Social Security website. The federal government is not going to lower it until they have a tax return that shows that you have a lower income. And they're always 2 years behind, because if you think about it, in November and December, they're going to be sending out people's Medicare premium forms, you know, to people that are already on Medicare, telling them what they're going to pay for 2026. And the federal government won't have access yet to your 2025 tax return, because nobody files it until at least January. You know, you've got between January and April, right? Or even till October if you file an extension. So for 2026, they're going to be looking at your 2024 income. That's going to be the latest IRS filing that they have. So we always tell clients is if you can project what your income is going to be, we recommend that you file an IRMA appeal. The worst thing they can tell you is no. But as long as you can substantiate, look, I had a reduction in hours, I retired, etc. This is what my income is now going to be. Then usually they'll lower it.
Okay.
And again, we can walk you through that process too. We've walked hundreds of people through that process.
This next question is more, I'll reword it a little bit. It looks like he's asking, what if my health changes in retirement and you offer me one plan? Is it something where you advise 2, 3, 4 years down the road where my health needs might change, an increase in coverage or a reduction in coverage? Or do we ever change courses per se in the middle of the race?
Yeah. So that's a great question, Matt. So when you first become Medicare eligible and decide that you're going to go all in and you're going to go on Medicare, you basically have two choices. Option number one would be to do what looks and smells and feels like your employer plan, right? And that's going to be a Medicare Advantage plan. It's going to bundle your medical, your hospital, and your drugs all together in one handy dandy little plan. And that insurance company, is going to be sort of in charge of your life, much like they are when you work, network-based, etc. And those plans have an annual election period every year, October 15th through December 7th, and you pick a new plan for for the following January. It doesn't matter what happens with your health with those. They can't ask you any medical questions. You can just change your plan just because you want to, right, during that time. But if you want to do option two, which is have original Medicare as your primary insurance, and then supplement that with a Medigap, or often called a Medicare supplement plan, that's a secondary insurance that you buy from a private insurance company to go with Medicare, and buy then a standalone prescription drug plan. You can change your prescription drug plan every year during that annual election period, but a Medigap policy only has one open enrollment period, and it's not annual. It's when you first go on Medicare or become eligible for Medicare Part B as in boy. It's a 6-month window, and during that first 6 months, you can apply for any Medigap policy that insurance companies offer, and they can't ask you any medical questions. After that, for that 6 months that your Part B is in effect, changing that Medigap policy is going to require medical underwriting. And the only reason to change it is because of the premium, right? The coverage doesn't change on a Medigap. It's exactly the same from one year to the next, but the premiums get more expensive as you get older. So it is easier to go from original Medicare with a Medigap and a Part D plan and say, this is becoming too expensive, I can't afford that anymore, and go to a Medicare Advantage plan where the premiums will be a lot less on the front end than it is to go from a Medicare Advantage plan. I mean, right now we still have a lot of zero premium Medicare Advantage plans. I think that will start changing in the future. But people often say, well, I'm really healthy. I don't want to be paying premiums for this other stuff. I can get a Medicare Advantage plan with no cost. And then all of a sudden they develop some sort of major medical condition like cancer, God forbid. 1 out of every 3 women, 1 out of every 2 men will get cancer sometime in their life. Now you can change from one Medicare Advantage plan to another, but if you've got active cancer or had cancer in the last 5 years, you're not going to pass medical underwriting to get a Medicare supplement or a Medigap. So this is part of the education that we give people, and we make sure that you understand that you're not just making choices for right now, but we help you understand that the choices you're making right now can have significant impact in the future. So, that's part of having an agent to actually advise you versus trying to do, what my neighbor said down the street I need to do.
It's really well said. A lot there to unpack. And I think that last answer really speaks to the point of why we have enjoyed working with Jo and her team. Jo really has the heart of a teacher. And
Yeah.
that's something that Randy has really given us vision here at the Price Group to do. We're trying to carry that out with Randy still here, obviously, every day doing that. But with that being said, that was all the questions we had. Jo, I want to thank you for your time. I know you have a busy schedule, and if anyone does want to reach out to Jo, there's her number. If you have any offline questions, feel free to email me. I can get you in touch with Jo
Yep.
as well. But
Yep.
with that being said,
And this email, Randy and Matt, this goes to me, this client services, but it also goes to my entire Medicare team. So, you know, this way you're not just waiting on one person to email you. You've got the whole team looking at it. And I just like to say thank you for the opportunity. I love working with you guys and with your clients. And you know, this is one of, I do lots of things in the agency these days, but this is one of my most favorite things to do. You know, I've taught my team to be all about education. And, you know, ultimately, you know, that's what we want you to know. We're here to work for your clients, our clients, and we want to advise you on your choices. We're not just here to try to sell you something.
well, the interests are really aligned in that between the
Absolutely.
clients. So, well, thank you all again for everyone that did join. Follow with Jo or herself with any questions, and wanted to say, stay cool and stay dry with
Yes.
the rain. And we'll look forward to hopefully catching up soon.
All right. Take care. Thank you.
Thank
Bye.
you. Bye bye.